Hi, my name is Atif Darwish, Professor of OBGYN, Asyut University, Egypt. An important practical topic of discriminatory zone or level in early pregnancy is a confusing topic. So I'd like to address this topic in a very short manner. Some gynecologists, when they are confronted with a case of amenorrhea and post-pregnancy cyst and they do not see gestational sac in utero, they are rushing or heroic in diagnosing a case of ectopic pregnancy. And many patients were operated on whether laparotomy or laparoscopy due to heroic wrong diagnosis. On the other hand, some others are reluctant in diagnosing ectopic pregnancy, and many patients were lost and many tubes were lost due to wrong diagnosis of non-being ectopic pregnancy. So the key of success is to define what is the case of ectopic pregnancy and how to exclude ectopic pregnancy exactly in a very strict manner. If you look to the literature, you will see very sophisticated algorithms and even using figures or diagrams. This is not very helpful in diagnosing ectopic pregnancy exactly in such a case. To properly diagnose a case of ectopic pregnancy, you should put in mind two things: correlation between the gestational sac visibility by ultrasonography and the level of beta HCG in the serum. So you should have two items for correct diagnosis or exclusion of ectopic or pregnancy. So the discriminatory zone or level is the lower limit of serum beta HCG level above which a gestational sac should be visualized by ultrasonographic examination if pregnancy is intact intrauterine. And this level should be, if you are seeing the case by transvaginal sonography, should be 1,500 to 2,000 international unit per liter or 6,000 international unit per liter if you are doing transabdominal sonography. Now you have a case with a period of amenorrhea and positive pregnancy test at home. She is coming to your clinic and you do ultrasonography. If it is transvaginal sonography, you should see an intrauterine gestational sac as early as 4 to 5 weeks of pregnancy. But if you do not see a gestational sac in utero, this is the first point you should put in mind, that you have to exclude ectopic pregnancy. And mind you that sometimes you see intrauterine a hazy, irregular, pseudo-gestational sac without decidual action. This is not a gestational sac. This is not a diagnostic of intrauterine pregnancy. Intrauterine pregnancy should be diagnosed by an intact gestational sac, regular with decidual action with hyperechogenicity around it. And in the first case, you can see the gestational sac outside the uterine cavity and there is a pseudo-gestational sac in utero, while in the figure below you can see an intrauterine pregnancy with an early intrauterine gestational sac. Mind you that some gynecologists rely on the presence of fluid in the Douglas pouch in diagnosing ectopic pregnancy. This is not always correct because normal females have fluid in the Douglas pouch as less than 10 milliliter, and near ovulation it can reach up to 20 milliliter of fluid in the Douglas pouch. If the patient has a history of induction of ovulation or ovarian hyperstimulation, she may have more fluid in the Douglas pouch, and the fluid is significantly seen by ultrasonography. And other differential diagnostic issues of ectopic pregnancy in such a case is inflammatory debris from a pelvic or appendicular infection or ascites due to liver or cardiac disease or malignancy. So don't rely on the fluid in the Douglas pouch alone as a diagnostic issue of ectopic pregnancy. Is not always free blood inside the peritoneal cavity. And you have to look to the echogenicity of this fluid in the Douglas pouch. If it is clear with lucent appearance, this is usually fluid due to transudation like ovulation or superovulation. But if the echogenicity increases, and this means maybe pus or blood, so you have to investigate such a case and to take care of this fluid more than the other cases of clear fluid in the Douglas pouch. So if you are suspicious of the nature of this pregnancy, you should order for serum beta HCG. If the result is negative, this is usually exclusive of ectopic pregnancy. But mind you that up to 1% of cases of ectopic pregnancy may have negative urine pregnancy test and beta HCG as low as 20 milli international unit per milliliter. And practically we see some cases of chronic ectopic pregnancy and even disturbed ectopic pregnancy with negative pregnancy test in urine or negative low beta HCG due to embedding inside the omentum or the intestine. So a negative beta HCG is not always exclusive of ectopic pregnancy. But if the result is positive, so you have a case with positive beta HCG and you cannot see gestational sac well inside the uterine cavity, in such a case you have to think of discriminatory level or discriminatory zone. What's discriminatory zone? I told you it is correlation between the ultrasonography and the level of the beta HCG in the lab. If by ultrasonography you can see an intrauterine gestational sac and beta HCG is more than the discriminatory zone, which is around 2000 unit per liter if you are seeing the case by transvaginal sonography, or 6000 per liter if you are seeing the case by transabdominal sonography. So this is a case of sure intrauterine pregnancy. You see a sac and you can find a high level of beta HCG in the serum. So this is the discriminatory zone to differentiate between sure intrauterine pregnancy and not sure intrauterine pregnancy. And what's the further management in such a case is just routine antenatal care of this case. But if you see no gestational sac by ultrasonography and beta HCG level is high, more than the discriminatory zone, so it is more than 2000 if you are seeing it, the case by transvaginal sonography, more than 6000 if you are seeing the case by transabdominal sonography, and you don't see sac, this is a case of sure ectopic pregnancy. You have to proceed to treat the case as an ectopic pregnancy because you don't see sac and the level of beta HCG is higher than the discriminatory zone, you know. The further management of a case of ectopic pregnancy is either expectant management, medical treatment, or surgical treatment. The selection of expectant medical or surgical management relies on the situation you are confronted with. If the ectopic pregnancy is only tubal and the patient is hemodynamically stable, without pain, without tenderness, she has unruptured ectopic pregnancy, she has a small mass which is less than 3.5 centimeters without cardiac pulsation, she has initial serum beta HCG less than 1000 international unit per liter and falling with time, and there is ability and willing of the patient to have strict follow-up in the coming few days. In such a case, you can offer your patient expectant management, which is watch and wait approach without any medical intervention, with frequent serum beta HCG estimation and transvaginal sonography performance. What is the objective of expectant management is to allow ectopic pregnancy to resolve on its own. What are the advantages? They include avoidance of the risks and side effects of medical and surgical treatment. The patient can be allowed to get pregnant immediately once the ectopic pregnancy resolves. Unlike methotrexate, for example, you have to avoid pregnancy for few months after completion of the course of treatment. And recent systematic review and meta-analysis found that there was insufficient evidence of a difference in the success treatment of the expectant treatment versus methotrexate. So many gynecologists are heroic in prescribing methotrexate and medical treatment. You can offer your patient just expectancy, waiting for natural resolution of the ectopic pregnancy, provided you are making strict follow-up without exposing your patient to this serious drug, particularly some cases with contraindications to methotrexate, or not offering your patient surgical treatment with risks of the operation. So don't ignore expectant management as a very good line of early ectopic pregnancy with the strict criteria already mentioned. But sometimes you can use medical treatment, and the criteria for medical treatment are the same for expectant management, and adding that there is no contraindication to the methotrexate. So the same criteria you allow you to offer your patient a medical treatment. Usually we offer methotrexate for inhibition of folic acid metabolism, halting growth of rapidly dividing embryonic fetal and placental cells. So this is another option. But the common practical mistake that all doctors go to the medical treatment ignoring the expectant treatment. But mind you that the success rate of methotrexate depends on the initial beta-HCG level. If the initial beta-HCG level is lower than 1000 unit per liter, the success rate may reach up to 90% of cases. But if the beta-HCG is more than 4000 unit per liter, the success rate is only 42%. So one of the strict criteria of selection of medical or expectant management is the level of the beta-HCG at the initial estimation. If it is more than 5000, it is not a candidate for expectant or medical treatment. You should go to surgical treatment directly. The option of surgical treatment is offered for your patient if she has failed expectant or medical treatment, or contraindication to medical treatment, or if the patient has heterotropic pregnancy, which is intrauterine and extrauterine pregnancy, or the mass may be more than 4 centimeters in diameter by ultrasonography, the beta-HCG level initially is more than 5000 units per liter, and of course if the patient is infertile, for fertility preservation in such a case. Most of the surgical treatment is done via laparoscopy using milking technique, salpingotomy or salpingectomy, and we can perform laparotomy in a very limited cases of instability of the hemodynamic status, and in such a case laparotomy is an emergency line of management. Again, the discriminatory zone shows you that the beta-HCG level is less than you know. You know that by transvaginal sonography, the level should be 2000 units per liter, transabdominal 6000 per liter, but the result comes with lower than these levels. And you see a sac in utero. This is a case of missed abortion. This sure diagnosis of missed abortion. A sac without high level of beta-HCG. What's the further management? In such a case, don't be heroic in doing evacuation or medical termination of this pregnancy. The patient has normal local and general examination. She is calm, no bleeding, no pain, no tenderness, and you have to offer her some time, expectancy. For 1 or 2 weeks does not matter. What's the harm of leaving a small sac in utero for this case? It doesn't matter for her and carries no risk. So the patient may have wrong dates, may have unreliable last menstrual period, the lab may have some technical errors. So wait some time for 1 to 2 weeks until another transvaginal sonography that confirms that this sac is empty and no extraterm pregnancy, no fetal pool. In such a case, you can terminate this pregnancy. The last option of the discriminatory zone, that you cannot see a sac and the level of beta HCG is lower than the discriminatory zone, less than 2000, less than 6000 by ultrasonography. What to do in such a case? No sac, lower level of beta HCG. What can I do in such a case? This may be a case of early intraterm pregnancy, a case of ectopic pregnancy, or a case of missed abortion. How to differentiate between these three conditions? Differentiation is very crucial in such a case. So we can wait for 2 days, and after these 2 days you repeat the beta HCG. If still no sac and beta HCG increases more than 66% compared to the initial measurement, this is a case of normal intrauterine pregnancy. As you know, beta HCG doubles every 1.4 to 2 days until 10 weeks of pregnancy. But if the level of beta HCG rises but less than 66%, this is a case of ectopic pregnancy in most cases, and you have to repeat ultrasonography. If you don't see gestation sac in utero, this is a case of ectopic pregnancy. So the doubling time is very important in differentiation between intrauterine pregnancy and extrauterine pregnancy. But if the level after 2 days decreases, this is a case of missed abortion. But you have to take care of the following issues. The rise of the level of beta HCG of 66% in cases of normal pregnancy is not a solid rule. If the initial beta HCG level was high, the rise is expected to be less than 66% of cases, and this is very important. Don't exclude intrauterine pregnancy based on the doubling time alone, because one of the studies found that if the initial beta HCG was 3000, the rise may be 33% only, and if it is lower than 1500, the rise is 49%. So don't rely on the doubling time of 66% as a diagnosis of intrauterine pregnancy alone. This is the first important practical point. The second point, that if you rely on the beta HCG discriminatory level of 2000 transvaginal and 6000 transabdominal without seeing intrauterine gestation sac as a diagnosis of pregnancy to being ectopic pregnancy, you should consider that the level of beta HCG should be very high as 3500 units per liter, to avoid the potential for misdiagnosis and possible interruption of intrauterine pregnancy that a woman hopes to continue. And this is a common mistake, that some doctors do beta HCG for the case and it comes with 400, 500, 600 and so, and when follow up the rise is not 66%, so it is a case of ectopic pregnancy, and he is doing laparoscopy or laparotomy or medical treatment for this case. This is wrong. If you rely on the beta HCG discriminatory zone alone as a diagnostic aid, it should be very high, as high as 3500 units per liter, and this is a recommendation of the American College. Again, another recommendation that you have to be suspicious, which means that even if the increased beta HCG pattern consistent with the doubling time of normal intrauterine pregnancy, don't eliminate the possibility of ectopic pregnancy at 100% of this case. You have to suspect ectopic pregnancy all the time until you see an intrauterine pregnancy with an intact fetal pulsations. On the other hand, if a woman with low beta HCG values and possibility of ectopic pregnancy is excluded, as the case is considered a non-pregnant, we cannot exclude ectopic pregnancy unless the level of beta HCG reaches 0 and non-pregnant level less than 5 units per liter, which because some cases of ruptured ectopic pregnancy occurred while the level of the beta HCG is decreasing or at very low level. So the message from this information is that you have to be suspicious, you have to be very careful. Don't rely on very high level of beta HCG as an indicator of being intrauterine pregnancy, and don't rely on very low level of beta HCG as the case is not a case of ectopic pregnancy. Some cases occur during these abnormal findings. And again, in twins pregnancy, the level of beta HCG is higher than singleton pregnancy at any gestational age. So the beta HCG increases traditional discriminatory beta HCG levels before ultrasonographic recognition, which means that you can see very high level of beta HCG without seeing gestational sacs of the twins. So don't be heroic in diagnosing of ectopic pregnancy in such a case. Now, I am confused. If I rely on beta HCG alone, this is not always correct in diagnosing ectopic pregnancy or excluding ectopic pregnancy. And if you rely on ultrasonography, this is not diagnostic of either diagnosis alone. So what's the best approach? The best approach is don't rely on a single item for the diagnosis. You should use your knowledge regarding clinical examination of your patient's symptoms and signs, the transvaginal findings, and biochemical correlation. You have to correlate between the clinical situation, the sonographic situation, and biochemical situation with strict follow-up, with proper counseling of your patient about the expectant medical or surgical approaches and strict follow-up of your case. This is the key of success of management of a case of suspected ectopic pregnancy. Thank you very much, and if you like this lecture, please press on the subscribe icon to have more lectures.